Hey, it's gonna take me like a few minutes just to set up real quick, so if everyone has to like pee or whatever, go now. Also, I know this is all gonna be stuff that you covered not too long ago, so like I won't be offended forever if you want to leave. But just know that I'll know. So. Also for those of you lurking, I've had Dropbox since I was in like 6th grade, so like don't judge too hard on the email. Just know that I've become a little bit more professional since then, but like I can't change it now, so. It's not the worst. I mean, it's not like Justin Bieber forever or anything like that, but. Uh, oh. There it is. Oh, okay. All right. So while this is downloading, just a couple things like to say like up front. I'm sure everyone's kind of given their like 2 cents on the BSCE one that's come up here so far. So I'm gonna give mine too while this is downloading. Don't stress out too much about it. I know that's like crap advice because I've already done it. So like in hindsight, but honestly, they're gonna curve it, and like most of the questions are very short. So they're very like much first order, and like there's gonna be things you don't know, and that's gonna be okay. So as long as you kind of get the bulk of like what's really really important, like, you're gonna be fine. Like no one's gonna fail it. Everyone's kind of gonna get through it. I know it's just stressful because it's like the unknown, but I feel like it wasn't too bad when I took it. I mean, I promise I wasn't one of the people that like took it drunk or whatever, but I didn't study too hard for it. And I was okay. So, and I, by me, under no means I'm like a genius or anything. So, you guys are going to be fine. Just kind of, keep in mind what's really important. Like, there's going to be some stuff on there, like, even for ours, which, like, since this is being recorded, just, like, I'll say some things, like, I've seen practice questions recently for some things, and just, like, keep in mind that I also had my BSCE 2 this past weekend, and they are going to test some of the same concept for you guys. So keep that in mind. I'm not saying anything that was on it, but I just will say I've done practice questions recently that have looked pretty similar. So that's kind of going to be the stuff I point out for you guys. I know you guys just did metabolism, like I said, not too long ago, but it's honestly huge. I mean, I think out of like the 4,000 questions that I had this weekend, I would say at least be like 30. Also, I love this picture, so like just give you a little bit of life because I know it's been a long while. So we'll go pretty fast. So starting out with metabolism, I know I just reviewed this with like some of you guys before I left you and you did neuro, but it is still really important. And I think the most important thing is like placing where enzymes go, because a lot of them look like the same thing. And it's very easy when like you get a question and you know like what the process is, like you know gluconeogenesis is working, you know like glycolysis is working, but the question is also, hi Molly and Jorge, why are you guys here? Just learning for term 4? Very cool. So all stars in the back. If I say anything wrong, you just yell at me. All right. So biggest thing is just to know kind of where to place the enzymes and where they go. So I put like a slide together with I think the ones that are the most important and pretty much all the ones that you're ever going to see. So also disclaimer, there's a couple processes they really love that you need to know like in and out, kind of like when they're working, and those are kind of gluconeogenesis and beta oxidation. Because like for an actual clinical problem, they're more concerned about hypoglycemia and hypoglycemic episodes than they ever would be with hyperglycemia. Because hypoglycemia is where you get like the coma, they can get ketoacidosis, like it's a big problem. Most of the time, like with deficiencies, like the hypo version is much worse than the hyper version. So a lot of times they'll ask questions about like gluconeogenesis because it is something that is more relevant. And if it's something that's not working, that's essentially saying that when your body is fasting, it's going to burn up glycogen real fast, and then you're kind of screwed. You can't generate glucose to do what you need to do. And beta oxidation comes in with that is because they're tied together. That was something that I stressed when we did this together in when you guys have the exam. But they're really important to like know that they're linked together because acetyl-CoA is one of those molecules that filters in everywhere. So in the terms of gluconeogenesis, they need acetyl-CoA, and that comes from beta oxidation. So if beta oxidation isn't working, so think like an MCAD deficiency. The reason that's such a big deal is that they can't produce the acetyl-CoA, and acetyl-CoA can't go into gluconeogenesis. And if it doesn't go into gluconeogenesis does not occur at all. So keep in mind that beta oxidation is what's going to generate the acetyl-CoA to go into gluconeogenesis. Like that link together, I think, is really big. That explains a lot of the conditions as well. Also, the acetyl-CoA that comes from beta oxidation is going to go into ketogenesis, which you should think about when you think about type 1 diabetics more than anything. Because ketogenesis is going to be that process that generates the beta-hydroxybutyrate and acetone that they can use for energy, especially when you go into like deep fasting. Like you need that to like essentially go on. Also, keep in mind with ketogenesis, this is really just type 1 diabetics because they're the ones that have or they don't have any insulin at all. Type 2 diabetics, you're really never going to see ketones in the urine. So if you see ketones, think type 1, just because you guys talk about diabetes so much. So there are some pathologies that they could ask you, like the actual pathological part of it too. Out of these, also keep in mind like fatty acid synthesis. This is honestly a process for me that I always forget. But like a couple concepts to keep in mind is that now fatty acid synthesis, you're taking acetyl-CoA that's coming from like the TCA cycle, and you're trying to put it into chains to store it away for later. So acetyl-CoA carboxylase is this enzyme that's going to take the acetyl-CoA and make malonyl-CoA. And that malonyl-CoA is what's going to shut off beta oxidation. So that's how these two link together. There can only be one running at this single time, and that's because malonyl-CoA is a direct inhibitor of this process. So some of the times with beta, with the BSCE, they'll ask you basic stuff. They'll ask like, gluconeogenesis is occurring, so what enzyme would you expect to be active? Or they can ask really in-depth stuff. Like for us, we got some stuff that was like super in-depth on the practice questions that we've done recently. So just keep in mind like that could be something that pop up. So that's just kind of talking about big concepts for you guys. Keep in mind the CPT, that's talking about the carnitine shuttle. So the carnitine is what's taking that acyl-CoA, and it's kind of moving it across the membranes and getting ready to actually break it down and do beta oxidation. But if that's not working, essentially you can't do beta oxidation at all. That's something you would think about with like an MCAD deficiency, like some process where you can't generate acetyl-CoA, then you can't do gluconeogenesis, and that's a big problem. Keep in mind, ketogenesis is HMG-CoA synthase, whereas cholesterol synthesis is reductase. Also, if you ever see HMG-CoA lyase, that also belongs to ketogenesis. HMP shunt, I know this is a metabolism thing, but just to kind of give you one location for all the enzymes you need to know. This has shown up for us recently. The G6PD, you should think like the G6PD deficiency, Heinz bodies, things like that. That's where this comes into play, because this is the process that's generating the NADPH, which is huge. It only goes in like a couple places, but what it's really, really big for is making the glutathione, which helps you detox essentially some of your free oxygen radicals. So if this isn't working, you get that buildup of the glutaperoxidase, or whatever the one is that's not glutathione. So you can't detox the free radicals, and that's why you can get the Heinz bodies, you can get hemolytic anemia, things like that. Isocitrate dehydrogenase, that should be under TCA. Heme synthesis, again, this isn't the metabolism part, but this is really important. This has shown up for us. ALA synthase, and then knowing that you need glycine and succinyl-CoA to make the ALA. It's really important that you know these are the ones that are filtering in to make your heme molecules. Just every so often, like the amino acids they point out are very specific for a certain process. So that means they're very testable. Also keep in mind that there's a CPS2 enzyme and there's CPS1, but they do very different things. If you see CPS1, you're thinking the urea cycle. If you see CPS2, you're thinking pyrimidine synthesis. PRPP aminotransferase, that's purine synthesis, which is de novo purine synthesis. And then bile acid synthesis is cholesterol 7-alpha hydroxylase. So that's kind of a run through of important enzymes that you need to know. Also this guy, bifunctional enzyme, and then a quick mention of these two. These aren't rate-limiting enzymes, but they're also like really, really important. Hormone-sensitive lipase is the one that everyone gets confused with lipoprotein lipase. So I'll talk about lipoproteins in a second, but just to keep in mind, like essentially they're moving free fatty acids one way or the other. So this guy, hormone-sensitive lipase, is cleaving them and releasing them into the serum so they can be used for energy. But lipoprotein lipase is one that's cleaving them from chylomicrons, from those lipoproteins that are dense in fatty acids, and tucking them away in adipose tissue. So this guy is going to be active when you're fasting, because that's putting free fatty acids in your serum, and you can use them for energy. So that's why it's linked to beta oxidation. Whereas lipoprotein lipase is going to be active when insulin is active. So that's the guy that's going to take the free fatty acids from like chylomicrons and put them in adipose tissue, so you can use them for later. And also this pyruvate carboxylase enzyme. So this is the guy that is going to make the, it's making pyruvate from oxaloacetate, I believe. And it's important because you need to know it needs biotin. Like, so that's kind of like the little nitpicky stuff they could pull up on your exam. Just because, like, also for you guys, keep in mind you haven't done, like, pathology yet. You haven't done, like, the pharmacology. So the test bank of, like, questions they're going to pull from you are going to be more heavy in, like, biochem and anatomy. Even like some of the histo stuff than you would usually see. Like it's not going to be the same stuff you see like when you get to my term, but like honestly, like the first half of our exam was very, very dense in biochem. So you do need to know some of these little nitpicky things. So like think carboxylases, you know they need biotin. When you think like dehydrogenases, know they need like NAD, FAD. And then things like hydroxylases, they need tetrahydrobiopterin. And kind of the other ones, the transferases are B6. That whole lecture from biochem is useful to review before you go into this exam. I don't think it would hurt you at all. Pyruvate carboxylase is an important one though. It's only with gluconeogenesis, so if you see it, know you're doing gluconeogenesis. Also, don't get this mixed up with acetyl-CoA carboxylase because that's kind of, this is in the fed state, and then this is in the fasting state. It's just easy to get them confused. This is a picture of the bifunctional enzyme. This is from first aid. I know Nikki and Ben just pulled up a bunch of first aid too. It's helpful just to, as a reference to know what's important, but it doesn't have everything either. So this is kind of their condensed version. The idea with the bifunctional enzyme is it's going to either turn on glycolysis or turn on gluconeogenesis. And the way it does this is like the main glycolysis gluconeogenesis like railroad. And off to the side here, they're going to either increase amounts of fructose 2,6 bisphosphate or decrease them. So if you're decreasing them, you're going to be doing gluconeogenesis, I believe. I have it like typed out on the next one. This is like me. Most of the time I'm a visual learner, but for this, like, it just got super wordy, so I had to break it down and be like, this is what's happening. So this is from my notes from DES. So essentially it's telling you like post-absorptive or fasting state, post-prandial or well-fed state, the hormone that's ruling, and then the processes you want to be active. So if I want these guys to be active, I'm activating this half of the bifunctional enzyme, decrease fructose 2,6-bisphosphate, and that allows gluconeogenesis and glycogenolysis to happen. Talk yourself through that a few times. It could show up. I think it's very important. It's a unique enzyme in itself because most proteins don't have two enzymatic domains. So it's easy to ask. It's also what's really controlling the fact if you're doing glycolysis or gluconeogenesis. So also keep in mind that glycolysis is that PFK1 enzyme and that gluconeogenesis uses PFK2 in its pathway. They love pictures like this, like EM images of cell organelles. I think Amir might have mentioned them because he did like FTM portion. If he didn't, know these pictures. Like, just like know the big pictures too, like even from like MCAT level days where they had the EM image where they showed the RER, they showed the Golgi, everything like that. Because what they're going to do is they're going to give you that as a picture and then give you some like biochem stem and they're going to be like, where in the picture is the, like their process active or something like that. So keep in mind you have your inner membrane, so here, and this is where the ETC is happening. They don't really ask a ton of questions explicitly about this, which is good because I think it kind of sucks because it's, I don't know, it's just something nitpicky to me. But what's really important is to know where things are going. So they're pumping the H plus out, and then after all the H plus get out, they all funnel through ATP synthase, and this is what's making ATP. So it's available in the matrix. And your TCA is also occurring in the matrix, and to get all the products they need for TCA, they use things like the malate aspartate shuttle, because glycolysis occurs in the cytoplasm. Knowing like locations of things I think is also pretty useful. It might have been useful hopefully for your biochem exam because I know I stressed my kids out about it. It could be important on the MCAT as well, or not the MCAT, the BSCE, never the MCAT. So this is probably something you haven't seen in a while, and it's either something you got and you understood for the exam, or something you kind of just crammed really hard and then you did the exam and now you've forgotten all of it. So no worries, because this was term 1 for you guys, correct? Yeah, okay. So this isn't as bad as it looks. Like the important things you need to know essentially are the 4 big molecules. So you have chylomicrons, and these are the ones that are actually like in the lumen of your intestines. So they're gonna like pull out fatty acids predominantly. So these are very rich in triacylglycerols, as are VLDL. So these are essentially pulling the triacylglycerols like from your diet. They're absorbed through the lacteals by ApoB48, and they go into circulation. And this is the one where like you just ate a meal, so that's why you're packaging all these fatty acids into this molecule. So you're in the fed state, so make that connection. And if I'm in the fed state, what I want to do is put those free fatty acids into adipose tissue, into peripheral tissues for storage. So that's why lipoprotein lipase is the one that's active in this case. So I'm taking the triacylglycerols from here, I'm putting it in adipose tissue, I'm putting it in peripheral tissues, and I'm using it. And then I kind of recycle the remnants. So chylomicrons are doing the aspect from the intestines to the liver. And then in the liver, the way the liver can get rid of some of the extra fatty acids it has is through VLDL. So chylomicrons and VLDL are the ones that are high in fatty acids. That's really important. They could ask you questions like that. I think we had a similar one recently in our practice questions that were not at all affiliated with the BSCE2. So none of those are high in fatty acids, and whereas LDL and HDL are primarily cholesterol. So VLDL is the one that's transporting fatty acids from the liver out into the periphery. So things like chronic alcoholics that have that skewed NADH-NAD+ ratio, one of the things that happens as a result of that is that VLDL can't leave the liver anymore. So that's why they can get a fatty liver, because they're not able to take those fatty acids from the liver to the periphery, because VLDL isn't able to release. Also, keep in mind we have LDL. So this is the guy that kind of gets the bad rep, but you do need him. He's taking cholesterol and like giving it to peripheral tissues and transporting it around. Other things to know, you do need to know your apoproteins. So ApoE is just kind of the one that's helping recycle If it's defective, you have beta lipoproteinemia. I don't know if they'll go after these disorders that much. I think the most important one is the familial hypercholesterolemia, because it has that like genetics tie-in. Like you guys have done genetics, so it's very viable for those to show up on your exam. Because they showed up for us much more than I thought they would. So definitely keep a lookout for that. If any of you are coming to review with me tomorrow, we'll kind of touch on some of the genetic stuff that like I need to review too. So ApoB48, this is one most people have a pretty easy time remembering. This is taking chylomicrons into lacteals to get them in lymphatics. LPL, we already talked about. This is taking free fatty acids from the dense lipoproteins and putting them into periphery. So this is going to be upregulated when insulin is active. So people that have like type 2 diabetes, that have insulin like going crazy, are going to have very high levels of lipoprotein lipase, just kind of like connection to make for your future studies and stuff. This is activated by ApoC2. That's really important. ApoC2 makes this guy be active. If he's not active, then you can't really get those fatty acids into your tissues. So you get the hyperchylomicronemia. So essentially you can't ever cleave those fatty acids from the chylomicron. So that's why they're high in the serum. CETP, this just throw out, this is a thing that exists. It's exactly what it sounds like. And then LCAT is an enzyme that's the lecithin cholesterol acetyltransferase. So this is going to esterify cholesterol. So if you ever see esterification of cholesterol, think this enzyme. And it's activated by ApoA1. So ApoA1 for LCAT, ApoC2 for LPL. And moving on. All right. So I also love this picture. And also this pathway is really important, which kind of sucks. But this pathway is huge because like it makes important things like dopamine that has a neurotie, norepinephrine, epinephrine is tied into everywhere. But the crappy thing is it's all different enzymes, it's all different cofactors, which make it great for testing, but kind of a pain to remember. So a couple of big ones to remember. Down here, you're making norepinephrine first. So keep that in mind. If you're kind of like judging if there's high levels of epinephrine or norepinephrine, like keep in mind epinephrine is coming from norepinephrine. So if there's some problem between like these two levels, think like somewhere in this step. That was something that was important for us recently, so I don't know why they like it so much, but it showed up in several of our practice questions. Keep in mind dopamine needs the vitamin C to make norepinephrine. Also just keep in mind that dopamine is what you use to make norepinephrine, because they do different things, but this is all the same pathway, and this all has to do with tyrosine. And keep in mind PKU, that's an important one. It's more they go after, I feel, in like the biochem class. I haven't really seen a ton of questions on it for like BSCE or step prep. But I mean, they talk about it so much in biochem that there has to be like a high yield aspect of it that will come eventually. But yeah, this pathway I think would be worth like trying to cram and memorize just because there's a lot of different aspects to it that they could ask about. Homocystinuria, this is something that I also bothered my DES kids about a lot because they could give you a question stem where homocysteine is high, and you need to know that extra detail they give you to figure out what the problem is, because homocysteine can be high in different situations. So it can be high with a defect in this enzyme or a defect in either of these vitamins. So one of the big things to know, for all of these, homocysteine is high. That's not going to help you find the answer. But if you see that there's connective tissue problems, like their lens is dislocated, like they have limb abnormalities, think cystathionine synthase defect. Don't think vitamins, think this enzyme. And I don't think it gets a fancy name for what it's called. I think it's just called homocystinuria. But it's unique in the sense you only see connective tissue problems with this disorder. B12 I think is like the most important because you get neurological problems. They're going to view someone that has like a megaloblastic anemia, which helps you eliminate cystathionine, but you're either between B12 or B9. And both of these are actually really rare to actually have defects in because you have a lot of stores of them. But if you see that the person now has like numbness and tingling in the extremities, you would be thinking B12. Yes? My mic's off? My mic's dead. Can you guys still hear me? Like genuinely? Okay, so that's fine. Less things to hold. So B12, neurological problems, honestly, that comes up so much in every single class ever since we learned this in biochem. It's unique. It's because the methylmalonyl-CoA accumulates. Keep in mind, you only see methylmalonyl-CoA accumulate in this condition. In B9, you just get that megaloblastic anemia. If they wanted to give you a little fun fact to figure out B9, besides like telling you, oh, they didn't eat their leafy greens or something, they would say that there's fig glue in the urine, which is just a metabolite that folate helps catalyze, so if there's no folate, this can accumulate in the urine. So keep those in mind. Again, like homocysteine is high for all of them, but there's only like this certain symptoms with that are unique to each condition. All right. Glycogen storage disorders. I'm honestly not going to read through this. This is just to point out that these do exist. Most important one is the von Gierke disease. I think this is the only one that would probably show up. The rest of them I don't think are particularly high yield. So keep in mind for this one, if you see a kid that has like bouts of hypoglycemia, their liver's big, they even have gout or like weird things, like things you would not expect to see from a kid. Think the glucose 6-phosphatase. So this is the one that's like actually putting the like gluconeogenesis pathway into glycolysis, or actually, sorry, it's putting the glycogenolysis into the glycolysis pathway. So this is going to help produce the glucose you need to fuel yourself in fasting states. So if you can't do this, you essentially can't use your glycogen stores, so they're useless, which is a big problem because gluconeogenesis takes a little bit to get started. So this kind of loses that buffer time. So that's why they can get the hypoglycemia, why they get the hepatomegaly, because now their liver has to work so hard because they can't rely on the glycogen stores at all. So know this one, I think, more than anything. If you're feeling ambitious, you can remember these. But I doubt anyone's trying to go for like 100 on this exam, so I think this one is knowing like enough. All right. Lysosomal storage disorders. Again, I don't know if like to put this in metabolism. Again, just like keep in mind these exist. One of the things that I think I messed up on, because sometimes I forget everything I teach you guys, is that with Hurler-Hunter syndrome, heparin sulfate and dermatan sulfate, like you see those sulfates, those are glycosaminoglycans. Those aren't glycosphingolipids, those aren't like sphingomyelinases, like glycosaminoglycans. So like that could be like the third order question they ask you, where they could say like some kid comes in, he has coarse facial features, corneal clouding. So what substances accumulate? And if they gave you glycosaminoglycans as an answer choice, that would be the correct one to pick. I tried to put in red the things that will help you pick out which disorder it's talking about. I would know the enzymes just in case they are trying to make this a harder question for you guys. But besides like reading them off to you, I don't think I can add anything to make it a lot easier. Just do practice if you can, memorize the slide, and you should be good. I know this is going to, this projects actually pretty well. So these are my notes on just like some buzzwords type of stuff. Like for biochem, you need some like little hacks to get you by. So this is available to you guys. Sorry, this is just kind of my scratch. Anyone that goes to my DS knows I don't make PowerPoints, so this is kind of me throwing together stuff like last minute to like give you at least something to present pretty well. So this is talking about like urinalysis testing because there's certain odors that are distinct to different conditions. There's metabolites that we talked about, like the figlu with B9 deficiency. BMA with pheochromocytoma. So keep in mind with pheochromocytoma, that's one that we'll talk about in the endocrine section, but it's episodic. So you would need to do a 24-hour urine collection to see if this is there at all. There's different colors. There's the serum electrophoresis, I think is important too. If they gave you one where you see this beta-gamma bridge, so I'll include a picture of it later. Think chronic alcoholics. Think someone that has like the cirrhosis of the liver where they have the upregulation of gamma globulin, so you see a beta-gamma bridge on serum electrophoresis. I don't know if they went after drugs and supplements for you guys. This was like my notes from biochem, so take it with a grain of salt. Just like try to use mainly like the urinalysis testing because they'll give you that information in a question set if they're trying to get at different deficiencies. All right, this is also just a shout out. I saw that Amiris, he mentioned the essential amino acids too. Just keep in mind, like, if they give you a question where they're saying something like someone has a nutritional deficiency, where they're not eating enough proteins, and they're just becoming like withered away a little bit. So if they're not eating enough proteins, essentially what they're losing is essential amino acids. So if the question is now which amino acid are they most likely to be deficient in, and they give you answers like alanine, pyruvate, things like that, keep in mind you're looking for the essential amino acids. So if they gave you like a lysine, but it was in the context of like the same thing where you have a nutritional deficiency, that would be the correct answer. Because if they gave you like alanine compared to this, you know alanine can come from your tissues. Think like the Cori cycle. Think like your muscles are very rich in alanine that can be broke off to go into things like gluconeogenesis. Keep in mind that there's a lot of different things that can become pyruvate that you can use for energy later on. But if you have like a protein deficiency, what you're really having a deficiency is one of these essential ones, because essential means your body can't make it. So don't forget that. Don't try to like get tripped up in the question stem. Think like, oh, well, they're losing muscle mass, so they must be deficient in alanine or something like that. Keep in mind they're trying to tell you that there's an essential amino acid loss. So remember those. These are kind of just nitpicky, but keep in mind that there's different transporters. Some important ones is the SGLT1. So this is glucose and galactose. So keep in mind they can kind of compete with each other if one is too high. Also really important is GLUT4. I saw that Amir mentioned this as well, but it is worth mentioning again. This is insulin dependent. So when insulin is there, it's going to put more of these in the membrane so you can transport more of the glucose where you need it to go. GLUT5 is fructose, and then GLUT1 has a low Km. So keep in mind Km means high affinity, or a low Km means high affinity, meaning anytime glucose is even around this transporter, it's going to be pumped into where it needs to go, which is important for stuff like RBCs especially, because they don't have a nucleus, so they essentially can't really do anything on their own. So and if they can't get glucose from the periphery, like, they're pretty much screwed. If there was like a problem with this transporter, you would expect to see like hemolysis, something like that. So this one is very sensitive to glucose, low Km, whereas things like GLUT2, this is a high Km, because this is on things like the liver and pancreas, which are always dealing with glucose. Like, you know how many processes go in the liver, and the pancreas is always dealing with like glucagon, insulin. So you want a high Km because you only really want them to be using the glucose when they need to, like when it's in a very high condition. They don't want to just pick it up anytime it's around, because they'd be picking up nonstop if that was the case. All right. This is just, I don't know if they'll go after this either. It's in first aid. I think the most important things to know are the ones that are really like the big problems. So if you have like a fructose problem, essentially like this is the one that would be like the big deal. So hereditary fructose intolerance, deficiency in aldolase B. So what happens is that fructose 1-phosphate accumulates, and that's a big problem because it can cause hypoglycemia right after you eat that food. So essentially this is like almost like a poisonous to the body, if you want to think of it like that. You get hepatocellular failure, whereas this one is asymptomatic. So they're probably not going to ask you a question on this one because it's not really important. The only really important thing is they had this rare condition. By comparison, you have non-classical and classical galactosemia. Non-classical is the one that's really not that important, but classical is the one that, like, if you have this, like, it's a big problem. So you have the, like, GALT enzyme, I think is how they abbreviate it usually. And where this one, galactose 1-phosphate accumulates, you can get hypoglycemia, hepatocellular failure. So think fructose 1-phosphate, hereditary fructose intolerance, and then galactose 1-phosphate, classic galactosemia. Those are the ones that are going to give you very big problems if they occur. So I think they're the most testable out of these, but I don't know if these are very testable at all. Just trying to mention it since we're doing this together. I also just, usually like in my reviews, I try to include pictures to like keep everyone like together, but I didn't have a chance to do a ton of that for today. If any of you come and review tomorrow, I'll try to have a little bit more for you to look at. So this is a big deal because anyone that knows me knows I hate talking about this stuff, embryo anatomy. I'm not an anatomy DES, but since we're talking about GI in itself, these are worth mentioning. So Meckel's, keep in mind this is talking about the Vittel duct, the rule of 2, so 2 inches from the ileocecal valve, or 2 feet, whatever, 2 inches. Anything you see with 2s, it's Meckel's. Hirschsprung, so this is going to be in babies, so this is a congenital condition. So the neural crest cells fail to migrate. Keep in mind that that's why this is not there anymore. So you have the megacolon. Achalasia, you lose the myenteric plexus, the LES can't relax, you get that bird beak appearance. And then omphalocele and gastrochesis are just going to be ones they show you pictures of. So know what the problem is if you had to define it. Also keep in mind that these guys, if they wanted to go after like something that was embryo heavy, rostral fold closure can cause sternal defects if it doesn't happen properly. Caudal fold closure can cause bladder extrophy if it doesn't happen properly. And then with these two, the biggest thing to keep in mind is that on phalocele, you see like the shiny little sac that's around the protrusion. But with this guy, there's no sac. It's just kind of the intestines are like out there, which is like a big problem. GI anatomy, I think the most you need to know is blood supplies. There's a lot of them. Like what they'll ask you, either this term or I guess like when you do pathology, I don't know like where to put the question exactly, is that if you have an ulcer and like it erodes, you know, the lesser curvature, like which vessel could be like at risk, or if you have one that like erodes the greater curvature, which vessel can be at risk. So things like that. That's their way of asking you an anatomy question in the context of like a pathology question. But that all has to do with knowing where these vessels are and what's going to happen if the area around them is eroded. So just keep those in mind. There's that great video on YouTube. I don't think it's worth it to spend 40 minutes to learn it now, but just try to get your bearings for that picture. Portocaval anastomosis, this could be explicit the question they ask you. Keep in mind that this is essentially saying there's portal hypertension, so the blood gets backed up. The portal vein has very high pressure in it, so all the blood kind of goes back systemically. So know where the different ones are. Esophageal varices I think is the most important because this is more common than others because this is where you'll see alcoholics. They can present with painless bleeding or they're coughing up blood. So that'll be a pathology thing you'll talk about later, but for your purposes now, you should know the anastomoses of these two. So definitely look that over. This is me. It's hard to see. Just with this picture is I found it in a research article, but it's telling you where things are absorbed. So one of the things that I talked about when we did this in GI Fist is that iron fistbro mnemonic, which is just telling you the different parts of the small intestines and what's absorbed in those parts that's unique. So you can look at this later if you take the picture and blow it up. But in the duodenum, you're really thinking iron. So the iron fistbro kind of goes sequentially. So iron is in the duodenum, jejunum is dealing with folate, and then the terminal ileum specifically is what's dealing with B12 and bile acids, which is most important. They have a lot of practice questions with terminal ileoresections, which might seem kind of random, but it's actually a more common procedure than you'd think because people with Crohn's disease or ulcerative colitis can have that occur. GI in itself is not really big for you guys yet, but when you get into path, it'll matter a lot more. So just kind of know your basics. This is the picture that I had drawn out for DES. This will kind of tell you where these regulations are occurring. Know that I think I have it typed down on the next slide, what's increasing gastric acid secretion, what's decreasing acid secretion, CCK is really important, and then pancreatic hormones or enzymes. So know where these are going. Know really the increased acid secretion I think is probably the most high yield if they do ask this. So gastrin, acetylcholine, which is coming from that vagus nerve, and histamine, which is coming from enterochromaffin cells. GI, also keep in mind, the histo tie-in is important. Know your different cells, parietal, panneth, all those random ones, and what they're producing. That could be a very easy question to get, so just we'll go over those slides real quick. It shouldn't be too bad. So endocrine, one of the things that I think most people forget about is the histo aspect of it, but it's definitely pertinent to be asked. So keep in mind with the pituitary gland, you have anterior posterior. Anterior is the one that's the surface ectoderm. Posterior is from the floor of the diencephalon, which makes you think neuro, because the posterior pituitary is axonal bundles you'll see there. So this is more neural tissue. Anterior pituitary, you have acidophils and basophils. So I think there's a big mnemonic that's the flat peg mnemonic, which will tell you everything that's made in the anterior pituitary. But I think most important is to keep in mind the B flat. Because if they really wanted to be jerks, we had a practice question recently that was where is a prolactin made? Essentially, they love asking about prolactinomas, which you've probably realized from neuro, which is also kind of random. So it'll be that person that presents with gynecomastia, they're producing milk for no reason, they're gaining weight, there's loss of libido, things like that. And they'll do a MR or a CT scan, and they'll see an enlargement in the sella turcica, which is where the pituitary gland is. They could also have things like double vision, which is that neuro tie-in. So knowing that it's prolactin, the third order or whatever question they can ask you is which cells produce prolactin. And that's what you need to know. It's acidophils. So know basophils, B flat, basophils, FSH, LH, ACTH, and TSH. And then note that growth hormone and prolactin also come from the anterior pituitary, but these are coming from acidophils, so they're kind of unique in that aspect. I think prolactin is really important. Also keep in mind prolactin is regulated by dopamine, so dopamine inhibits prolactin secretion, and that's really the only thing that's directly feedback inhibition on prolactin. Posterior pituitary, keep in mind there's these things called Herring bodies, and these are storing the hormones for when you need them, because the posterior pituitary isn't actually making them. They're receiving them from the hypothalamus, so the SAD-POX mnemonic, ADH, and octocitins, they'll be stored in Herring bodies until you need them. I think histo is relatively high yield for endocrine, so definitely look those over. This isn't to freak you out, because I still don't know this, but just keep in mind a couple really important ones. So knowing that insulin and IGF-1 are tyrosine kinases, I think is worthwhile to know. So IGF-1, people kind of forget where to place this sometimes. So this is the one where the growth hormone is acting on your body to produce IGF-1. And essentially it's the IGF-1, which is the insulin-like growth factor, that's like completing the action of growth hormone. So growth hormone releases the IGF-1, and the IGF-1 is what makes your organs bigger. So think of things like acromegaly, where they can get the enlargement of the organs, they can get like the big hands, like the coarse facial features, and that's all because there's such high levels of IGF-1 that are circulating around and affecting different parts of the body. I mean, all of this could be testable. I think those are like a couple unique ones that you should know. Also for IP3, like a lot of times the way I think of the IP3 pathway is that it's essentially trying to make more calcium. So these are a lot of the hormones that are like constricting things. So you think like oxytocin is contractions of the uterus. So like the actual action of muscle contracting needs calcium. So it makes sense to me that this is the IP3 pathway. So that's something I can kind of logic out for myself if I see it on the exam. Angiotensin 2, we know that's constricting vessels when you're in hypovolemic states. And then the other ones are kind of just like you got to memorize them eventually. I don't think it's particularly important for you guys, but I'm just mentioning it in case it does show up so I can say like I said it pretty much. So thyroid disorders, really important. Hopefully it's not too bad and that you got this down when you did endocrine. Just kind of a friendly reminder that this is like a path question, but like they do mention it for you in several different subjects, like histo, I think they mention it. They mention it in physio for sure. So it could be brought up. Know that these are like autoimmune conditions, so they're making antibodies against different parts of the thyroid. So Hashimoto's, the antithyroid peroxidase antibodies and antithyroid globulin, so this can create that hypothyroidism. So this can be someone that's gaining weight, they're fatigued, they have like the cold intolerance, whereas hyperthyroidism is going to be someone that's like hot all the time, they're losing weight, their BMR is like crazy. Also keep in mind with Graves' disease, a couple unique things, as you see pretibial mixed edema, and they'll have that exophthalmos. I don't know, like sometimes with the anatomy questions they ask like more path things, so mentioning that there. Keep in mind that thyroxine is T4, thiidothyronine is T3, and that you make a lot more T4 than you do T3. Even though T3 is more potent, it has a very short half-life, so it's not really useful to have in high amounts. So you have a lot of T4, and then in the peripheral tissues, it makes T3 via 5-deiodinase. So these are the levels you'd expect to see for these different conditions. Keep in mind, like if you're talking hypo, this is talking about like T3, T4 circulating around, mainly T4. And that these two will just kind of tell you where the problem is, if it's at the thyroid gland or if it's further up. My friend Jen loves this picture, so I told her I would include it in there. So for one of our like path lab slides, she tried to put it in on my slide because I had diabetes, and I had to realize right before the tutor came and sat down to take it out. So diabetes is something that you'll cover much more in future classes. For your purposes right now, like there's the buzzword for histo, that's the Kimmelson-Wilson nodules. So that'll be something where you see like a glomerulus, and then inside of it you see a lot of pink space. So the pink space is essentially the deposits of sclerosis, essentially. So in diabetes, one of the big things is they can have nephropathy where their kidneys are damaged, so Kimmelson-Wilson nodules. Metabolic changes are probably the most important for you guys right now that they could ask about. So you have increased gluconeogenesis and glycogenolysis, because essentially your insulin's not working. So your body's always reading that you're in a fasting state. So you're making a lot of glucose, so that's why you get the hyperglycemia that you have to manage over time. Increased proteolysis, so you're breaking down muscle and creating pyruvate from amino acids. Increased lipolysis, so beta oxidation. Keep in mind, beta oxidation is producing the acetyl-CoA that goes into gluconeogenesis, so they're linked together. Also keep in mind you get the hypertriacylglyceridemia because you're not breaking down chylomicrons and VLDL. Essentially your body just doesn't know what's happening anymore and it's not regulating itself very well. What's mediating the damage for the most part is the advanced glycosylation end products, the AGEs. Also keep in mind like this is a biochem tie-in, the sorbitol aldose reductase. So sorbitol is osmotically active, so if you leave it sitting around, it's going to pull water in that can produce cataracts. All right. This is probably something that Nikki and Ben might have talked about, but just to mention it again because it's kind of like an endocrine thing too, because you talk about SIADH, so I'm just mentioning it here too. Sorry this is blurry. I'll fix that later. Keep in mind like ADH is always trying to reabsorb water, so if I have inappropriate secretion of ADH, I'm reabsorbing a lot of water in my plasma, so that's why the plasma osmolarity goes down, because it's essentially diluted. And I'm taking all that water out of what would be in the urine. So essentially all that's left in the urine is like the metabolite, so it's hyperosmotic. And then I have a decreased urine flow rate because all of that water is gone. And by comparison, like in this condition, ADH is high and it's working. So you see the effects of ADH increase in the body. Whereas diabetes insipidus are ones where ADH is not working for one reason or the other. So central diabetes insipidus, in the question stem, what you would see is a patient that was in a car crash and they had head trauma. Because essentially what's happening here is now you're not releasing ADH anymore. Like your body is not regulating itself, it's not releasing ADH. So you see all the effects you would expect to see if ADH was not there. You're not reabsorbing water from the collecting tubules anymore. So essentially your urine gets super diluted because all that water just sits in the tubule and you pee a lot because you're not taking that water out. And as a result, you can get hypotensive and then your plasma osmolarity goes up. But in this case, it's just they're not releasing it. There's no problem essentially with the ADH in itself. It's just that it's not released at all. So in this case, they would respond well to like vasopressin if they gave it to them. Whereas nephrogenic diabetes insipidus is kind of like, I always compare it to type 2 diabetes, where type 2 diabetes, you're resistant to insulin. In this case, you have a defect in like your V2 receptors, so you're essentially like resistant to ADH. Even though your body will crank it out to try to fix itself, it's not working. So you see the same like lab results for both of these conditions, but keep in mind this is you're not releasing ADH appropriately, and this one you're releasing ADH, but there's a problem in the receptors. So the different columns with the osmolarities and flow rate is something that could show up on the exam. I wouldn't put it past them to put on for you guys. I think it's really important. Calcium is important to keep track of as well. And it questions them if they told you they have where they tap on the jaw and they jerk, which is the chopstick sign. I never know how to pronounce it. And the trousseau sign is the one where if they put the blood pressure cuff off and they tighten it, their hand will start spasming if they leave it for too long. So these are signs of hypocalcemia. So they're saying that there's something out of whack with like calcium regulation itself. Important regulation you need to keep in mind is calcitonin is coming from thyroid, so the C cells. So this is trying to tone down calcium in the body. So you're increasing osteoblast, you're trying to put it more into the bones. But calcitonin in itself doesn't have a huge effect on blood calcium. But for your purposes, you should know that it's kind of doing the opposite of parathyroid hormone. And that parathyroid hormone has different effects in different places. So this is going to be released appropriately when you're hypocalcemic because it's going to try to break off the calcium from bone and affect your intestinal absorption to get you more calcium that you need. So in this case, the chief cells in the parathyroid gland are making PTH. Also keep in mind the parathyroid gland is that third and fourth pharyngeal pouch. That's an embryo question they love. So think of things like George's syndrome. It could pop up a million times for you guys. So one of the things that's affected in George's syndrome is that they don't have that parathyroid gland, depending on how severe it is. So third and fourth pharyngeal pouches. And what this does is it's going to indirectly stimulate the osteoclasts. So it's going to stimulate osteoblasts first. And then as a result of that, osteoclasts are stimulated secondhand. So that sounds kind of counterintuitive. Just know it's indirectly affecting osteoclasts, but osteoclasts are upregulated. So I am resorbing calcium from the bone. One of the important layers that you should have added on last term of the CPR module is that PTH also works in the tubules. So in the distal tubule, it's going to increase calcium reabsorption, and in the proximal tubule, it's going to decrease phosphate reabsorption. So it's sometimes called the phosphate trashing hormone because you lose a lot of phosphate at the expense of reabsorbing calcium. Really, really important, the 1-alpha hydroxylase enzyme is what's making active vitamin D. So vitamin D isn't calcium, but it plays a huge role in calcium metabolism. So active vitamin D is that 1,25-dihydroxycholecalciferol. Shorthand is calcitriol. So this is in the kidney. So think of someone with renal failure. This would be a big problem. So when you make more active vitamin D, essentially that's allowing more intestinal reabsorption of calcium. So you have different layers that calcium is regulated. I think they're all important. Keep in mind with parathyroid, you can get hyperparathyroidism, and there's different degrees of that. You can have hyperparathyroidism, like a primary version, where you have a tumor or something that's on your parathyroid gland that's inappropriately secreting parathyroid hormone. Or you could have something like secondary hyperparathyroidism. And that one's unique because if you look at the lab values, calcium is low when you look at it. So essentially it's reading that calcium is low and that PTH is going to be crazy high. So just think of it that it's responding to something. So secondary to low calcium, you have high parathyroid hormone. So keep in mind the different layers that calcium is regulated. I think it's worthwhile to keep in your mind. Adrenal glands, keep in mind the different zones. So keep in mind you have the cortex and medulla. So something that only affects the cortex will have no effect on the catecholamines. So keep those separate. So glomerulosa, aldosterone, fasciculata, cortisol, reticularis, androgens. This is something they could ask you, those nitpicky enzyme questions like the 11 hydroxylase 17. I still don't like know that chart. Honestly, they throw that chart in like every lecture now, and I still like refuse to like learn it. I will learn it before the step. All I remember right now is that like, you know, that little one hack where you make the two columns. So hypertension and the secondary sex characteristics. So you put the numbers down. Every time you see a 1, you put an up arrow. If anyone doesn't know that, life-changing. See me after. I will show you. That usually will get you the question. If they give you like the symptoms, you can figure out which enzyme it is. It's a little bit nitpicky, but like I think that'll work for your most part there. So that's cortex. And then medulla, you have chromaffin cells. So they're described as modified postganglionic sympathetic fibers. So you're thinking chromaffin cells are like, think the tie-in with pheochromocytoma. So pheochromocytoma could be a tumor that's in the adrenal medulla, so you're making a lot of catecholamines, so your norepinephrine, epinephrine. So that's why they get the episodic fits of like sweating, tachycardia, things like that. But keep in mind it is episodic. That's something they'll drive in more when you get into pathology class. But keep in mind you're looking for the VMA that's in the urine, the mandelic acid, and that these guys are broken down by the MAO enzyme. Some important disorders, Addison, so your primary adrenal insufficiencies, you're not making aldosterone and cortisol, so you can kind of infer what you would see on lab tests if you don't have either of those. Aldosterone, keep in mind that's reabsorbing sodium and water follows. And that cortisol essentially has like the opposite effect of insulin in pretty much every aspect. So it's mainly a catabolic hormone, so people with like Cushing's syndrome are going to have things where there's like high triacylglycerols, essentially everything that's opposite of what insulin is doing. For the most part, for your purposes, that's all you should know. Also keep in mind Cushing's syndrome, if they want to be jerks, keep in mind that like Cushing's syndrome is a broad term, but Cushing disease is a specific term. So Cushing's disease refers to that the tumor in the pituitary gland. So if you have a tumor in your pituitary gland that's making too much like CRH, you can get Cushing's syndrome as a result of that. Or Cushing's disease as a result of that, and then Cushing's syndrome, just look for your, like, the moon faces, the buffalo hump, purple stripe, all of that. And then Conn syndrome, you have too much aldosterone. I put here that renin is low. You should know, like, the RAS system pretty much in and out. I think it's very, very important. So essentially, they're reading that aldosterone is very high, so renin's going to be very low in an attempt to, like, stop making aldosterone. But the problem is that there's, like, a syndrome where you're making aldosterone inappropriately, so it's not going to really help regulate that too much. Last section, reproduction. So there are important embryo things for this too. Honestly, like hypospadias and epispadias have shown up so many times for us in term 5 and like so many times recently too. So hypospadias is on the ventral surface of the penis, so this is due to failure of urethral fluid to fuse. And then epispadias is on the dorsal surface. So like one of the mnemonic things is that you see the E and you're thinking you're gonna like pee in your eye. So like I starts with E, epispadias starts with E, so it's on that like dorsal surface of the penis. And this is faulty positioning of the genital tubercle. Oligohydramnios and polyhydramnios I think are also pretty important. You should have talked about them in your anatomy class pretty extensively, hopefully. So this is essentially saying that that fluid that's in the placenta. So there needs to be fluid because that fluid is essentially like helping the baby develop. It's going to be exposed to like their lungs, like they're swallowing it in, and that most of the fluid that's in there is the like fetal urine in reality. So if they have like a renal problem or something, they might have problems producing too much fluid, but they really need it. So oligohydramnios there's not enough fluid, so you get pulmonary hypoplasia because you're not like inhaling the fluid anymore. So their lungs aren't experiencing that fluid. The lungs develop inappropriately. You'd also see fetal compression, so they'll have like limb deformities. Polyhydramnios, there's too much fluid. Really important in the tracheoesophageal fistula. So this is where this comes into play. Esophageal duodenal atresia, think like it's ending in a blind pouch. And anencephaly, so they have problems with the development of the head. One of my friends said like something that was high yield for her in recent times that she got stressed on is like important gestational weeks, which is super random and kind of sucks. So I pulled out ones that I thought were like the most important if they like try to ask them for you guys. So gastrulation, keep in mind ectoderm, mesoderm, endoderm. They could ask you questions on like what derives from each of these layers. Hopefully they wouldn't. I don't know. I always have the hardest time remembering that. But I think it's worth looking at for you guys. Weeks 3 to 8, the teratogens. So know the different kind of syndromes that like you've been exposed to so far. So if they mention fetal alcohol syndrome, know that. Know like what you would expect, the microcephaly, the intellectual problems. Week 10, female, male, and then week 25 and 26, that's when surfactant starts being formed. And surfactant is one of those things that pops up in like every respect, and it's always really, really important. So like one of the indicators whether a baby can be delivered or not, if there's enough surfactant in the body. Because if there's not enough, as soon as they're born, their lungs are going to experience very high surface tension, because the job of surfactant is to decrease that surface tension so the lungs can operate properly. So if there's not enough surfactant, they need to give like corticosteroids or something to stimulate surfactant synthesis. But just keep in mind, like around these weeks is when it's starting to be made. And usually I think they say around the 35th week is the one where it's like a sufficient or something like that. But you can double check me on that. So reproduction, hormones are important. I kind of just pulled out everything I saw from like your histo lectures where they talked about hormones that I thought was worthwhile. Honestly, like repro in itself, you should know like 80% of everything about females and like 20% of things about males, because those are usually pretty simple. Females are like super complicated because you have all the different histologies, all the different follicles, components of that. But know kind of analogous structures too. So know like in the males you have the Leydig cells that are making testosterone, Sertoli cells make inhibin B. They make other things too, but inhibin B is important because that's what's regulating FSH. So repro and endocrine, like keep in mind everything is feedback regulated. So if one thing is out of whack, it's going to throw off the whole system. So say like for instance you had a disorder like I think it's Klinefelter syndrome, where you have just genesis of seminiferous tubules, and this is where these cells are. So if the seminiferous tubules aren't developing properly and you don't have a lot of inhibin B, you're going to have really high levels of FSH because now it's not being inhibited anymore. So keep in mind like those cycles. I think this is the most important one you need linked to Sertoli cells, Leydig cells, testosterone, those Rink crystals. So look at like an EM image of that because I think that's a unique cell that you should know. That's going to tell you this is a Leydig cell. Important reactions in making these hormones. Just to pull them out because sometimes everyone gets these enzymes mixed up. So you have desmolase that's making the androstenedione. You have aromatase that's making the estrogen in the periphery. Which, like, interestingly enough, a lot of patients that like have like morbid obesity have a lot of fat tissue, and a lot of fat tissue it contains this aromatase enzyme. So that's why they can get like syndromes where like they could get like gynecomastia, things like that, which seems like a little bit out of place. But if you have someone with like chronic obesity, and they have all that aromatase that's sitting in their adipose tissues, they can get high levels of estrogen too as a result of that, which I think is interesting. So like try to keep that in mind. Aromatase is really important. Keep in mind aromatase 2, that's made by the granulosa cells for females. And that testosterone and DHT is 5-alpha reductase. So this is like really important when you talk about like things like benign prostatic hyperplasia, because this DHT is what's going to make that much worse, because DHT is very potent. Because you have that spectrum with like the estrogens like estradiol, estrone, estriol, and then you have the spectrum with testosterone and DHT, like which ones are most potent. So DHT for like males is most potent. Obviously it can exist in females as well, but usually we talk about it in the context of males. Progesterone is an important one to keep track of for females, and the way they'll try to tie this in with like fetal problems is when is progesterone being made and what is making it. So first trimester, you have this HCG, which is from syncytiotrophoblasts, which are the ones that are like in the periphery, if you look at like a picture of it. And these are stimulating the corpus luteum to make progesterone. So first trimester, the mom is making progesterone. Second and third trimester, the placenta makes its own progesterone. So keep in mind what's mainly contributing progesterone during these different trimesters. I think it's something that's easily testable if you're getting like a test maker that like really wants to talk about everything fetal and development-wise. This is also a contribution from one of my friends too. She found this in like Italy or something. Just to keep you interested because I hate this picture, or like I don't know. I feel like it gives everyone a little bit of stress, but it's not too bad. Histotie-ins is that primary oocytes, secondary oocytes, which phase they're arrested in. I think is worthwhile. And then ovarian cycle, you have to know it at some point. If you're still having a lot of trouble with it, look up a YouTube video or something. Most important things is, which I like that first aid breaks it out like this, is that you talk about like the proliferative phase. It's also called like the follicular phase, but they're talking about different parts of the female reproductive system. So when you say follicular phase, like it's talking about the same time period, but you're talking about ovaries when you're talking about follicles, because this is where the follicles are developing, and then the endometrium is what's proliferating. So this is occurring during this phase, so it's called the follicular phase. It could also be called the proliferative phase, just kind of which organ you're talking in respect to. So this is follicles developing. Most important thing is that estrogen is the one ruling this phase. So estrogen, you're thinking follicular phase, sorry. And that FSH is the one that's stimulating estrogen to be produced. So if you think of something like menopause, during menopause you essentially have used up all those follicles, so you're not making a lot of estrogen anymore. So like one of the biggest indicators that someone is going through menopause is that FSH is crazy high, because now it doesn't have that feedback regulation with estrogen anymore. Because if this is gone, essentially this is going to keep being released, keep being released, keep being released to try to upregulate estrogen. But essentially like the female would need to have hormone replacement therapy or something, because they can't really make much of their own estrogen anymore. Ovulation, biggest thing to know, is triggered by this LH spike. That's hugely, hugely important. And that once LH spikes during the luteal phase, progesterone is essentially ruling. So luteal phase, progesterone, this is also called the secretory phase. So this is where like those spiral arteries get like super coiled, and eventually they'll deteriorate. So FSH, estrogen, this phase, and then after ovulation, progesterone is doing pretty much all the work. Genetic problems, I'm sure these have been talked about. I saw that Amir mentioned this too, which is a reflection of what happened in recent times for us. I forgot what this was, so keep in mind it's a trinucleotide repeat. If they question them, they always will give you the macroorchidism in a male, large jaw, large averted ears, mental retardations, fragile X. Turner syndrome, very high yield. It pops up everywhere. I think it's like more common than other things, so it's like worthwhile for them to keep mentioning over and over and over again. So this is the 45X. So most of the time it's due to meiotic non-disjunction. It could also be due to mosaicism or structural abnormalities in the X chromosome. You have Klinefelter's, which is also meiotic non-disjunction. And this one they have that extra X. So essentially this extra X is the bar body. So keep in mind, bar bodies are activated X chromosomes. Like if they asked you to describe it in like the genetics aspect, no, it's inactivated. But with these patients, they get like a lot of female characteristics as a result of having this extra X just sitting around. Biggest thing to know about Klinefelter's is that you're losing the seminiferous tubules, especially like Sertoli cells, like I mentioned earlier. So you'd have really high FSH because it's not being inhibited anymore. Cartogner syndrome. So if you saw someone that had like their organs flipped around, so if the heart was on the right side now, and if they're having like a lot of sinus infections, if they're having trouble getting their wife pregnant, things like that, think Cartogner syndrome. So primary ciliary dyskinesia, mutation in dining arms. I think it'd be worthwhile to go back and know those like little protein molecules like desmin and muscles. There's like vimentin, even like things like the bullous pemphigoid, stuff like that, like hemidesmosomes, like that level of histo could show up for you guys. Again, you guys haven't had all the path yet, so they're going to pull questions from things you have had, which is sometimes is nitpicky stuff. So dining arms, that's talking about the cilia. So if you don't have cilia, it makes sense why all of these are affected. So this would affect, like, because the sperm don't have the cilia to be motile anymore. Situs inversus, which just has to do with, like, development. Chronic sinusitis, so they can't clear out the mucus very well because you don't have that mucociliary escalator working properly. Double Y syndrome is something that's mentioned in the first aid, which is kind of random. It's paternal non-disjunction because you have that extra Y. But this patient, you wouldn't really ever see any problems. Like, they have normal IQ levels. They usually have, like, normal fertility, which is kind of odd. But if it does show up, just know paternal non-disjunction. Like, they could go for the genetics aspects of this, like the non-disjunctions, where they fall in, what a bar body is, or they could ask you the reproduction aspect of, like, inhibin FSH. And I think, okay, so a couple miscellaneous things that are important from this section. Pap smears, so this is screening for cervical cancer. And, like, this is, like, revolutionary. I mean, this decreased the incidence of cervical cancer, like, markedly, to where now it really isn't something that, like, kills women anymore because they always can catch it. So for your purposes, know the histo. So know, like, the endocervix is simple columnar, ectocervix is the squamous. So if you see the squamous starting to take over this columnar cells, think like they're at risk of cervical cancer now, so that transformation zone. Prostate cancer and BPH, they love this question of like which zone is affected where. So prostate cancer is the peripheral zone. This is where a lot of your glands are. And then BPH is the periurethral zone, transitional zone. And this is the one that sits right around the urethra, the membranous urethra. So that's why the patients with BPH will have the starting and stopping of urination because they're being directly compressed by that zone right around the ureter. Hydrocele is just fluid in the tunica vaginalis because maybe it didn't close all the way. That's where you do the flashlight test. And that varicocele is more common on the left. So on the left side, you have the left testicular vein that drains left renal, that drains IVC. So there's this extra renal step in here, which is more likely to be compressed. So that's why it's more likely on the left side, where the right side it just goes straight to the IVC. There's really no like middleman, so it isn't as common. I think that's all for me. Thank you. Since I'm last, if you guys have questions, let me know. I'm sure you guys are exhausted, so that's fine. And then I'll see some of you tomorrow if you want to review stuff still. But have a good night. You're going to be fine. What? My TES group. So, yeah. Oh, that's fine. She'll post it in the class page, too.
I mean, I know you probably
Yeah, so you just want me to leave it up?
You did a great job.
Thanks, sorry.
Thank you so
All right.
much for your time.
I think this is over.
Oh yeah, I gotta cut that one off too.